So welcome everybody. This is a CIN webinar, Collaborative Care Model for Perinatal Mental Health. This webinar will introduce the collaborative care model, which is an evidence-based approach to integrating behavioral health into primary care with a focus on addressing perinatal depression. So during our time together, you'll learn about the model itself. You will get to hear about a Los Angeles-based initiative, and you'll hear real-world insights from two community health centers doing this work on the ground in Los Angeles. So my name is Marie Hubbard. I'm part of the team that leads the California Improvement Network, or as you've already heard me say, I will be using the acronym CIN. CIN is a learning and action community that advances equitable healthcare experiences and outcomes for Californians, and we do that through cross-sector connections, spreading good ideas, and implementing improvements. CIN is a program of the California Healthcare Foundation and then managed by Health Force Center at UCSF. So the program office team that I'm a part of is at Health Force Center, and then the program is funded by the California Healthcare Foundation. You can learn more about our organizations by visiting our websites. One last thing before we get into the content today. The essence of CIN is really based in co-design. And what we mean by that is that everything that we do and put out through CIN is really built by our partner organizations, but also by all of you who participate and attend each of our webinars that we host. And so we really want to ensure that whatever content we're delivering is useful and timely and really supports your work. So at the end of our hour today, there'll be a 3-question poll. It's really quick, I promise. And so we hope that you stay through the hour, one, because this content is great, but also so that we can hear your feedback on how we can continue to support you and your organizations. So with that, I'm going to introduce our first 3 speakers. We'll have a second set of introductions about halfway through our time. So first we have Ian Bennett, who's a clinical supervisor, Solano County Department of Health. And then our colleagues at the Community Clinic Association of Los Angeles County, we have Matt Moyers, Senior Director of Clinical Services, and Amy Kin, who's a project specialist. And so we'll be starting with Ian, who will be kind of giving an overview about what the collaborative care model is, and then dive into this Los Angeles-based initiative. So with that, I will pass it over to you, Ian.
Thanks so much, Marie, and hello, everybody. I'm really excited to be able to be here and share some of the work that's been done over now decades around collaborative care more generally, and also on our specific project focusing in on people in pregnancy and postpartum suffering from depression and the risk of suicide. Next slide. So let's talk a little bit about maternal mortality. This is one of the things that is often really surprising to people, that it turns out that death by suicide, which is attributable to, in almost all cases, to being able to identify depression, that suicidality is associated with a major depressive disorder. It's one of the criteria of depression. You don't have to have that, but it's a common criteria. We now know is a leading cause of maternal mortality. And as is described on the slides here, most suicides occur among people with those with depression. Most of those occur between 6 to 12 months postpartum, which historically is a period where we don't have a system of care set up for someone who's given birth, so that birth parent. And it is one of the major reasons that Medicaid funding in California and in Washington, where I was until recently, Washington State, were extended to a full year postpartum, was specifically because of this finding that the death by suicide is such a high risk of maternal mortality. Luckily, death by suicide is rare, but it is still a leading cause of maternal mortality. So it's important to know that depression is our most common disorder of pregnancy. In general, we talk about populations of being 15 to 25% prevalence, meaning that at any one moment, if you were to look at a cross section of people in pregnancy and postpartum, you would find between 15 and 25% of those people make criteria for major depression. And that is something that is the most common disorder of pregnancy and postpartum. So next slide. So as I mentioned, it's quite common. There's both minor and major depressive episodes. Major depression is what we know is associated with all kinds of difficulties, both for the pregnant person and their offspring. So people in pregnancy and postpartum are more likely to have preterm birth, low birth weight, and other issues during their pregnancy. The child, the offspring, is more likely to have lowered cognitive and linguistic development, and that's shown both in the US as well as the rest of the world. In parts of the world where food is not as easily obtainable, you also see growth restrictions as well, or reductions. And that goes away or is greatly reduced when somebody is treated for depression and gets better. Next slide. The collaborative care model is something that Southern California in particular has a lot to be very proud of. That's where the first trials that show the incredible benefit of collaborative care model over usual care for depression in primary care. And this is an interesting and different kind of model than you might be used to for integrated behavioral health. It is an integrated behavioral health model, but the focus is not on handing patients off to a mental health specialist, but rather enhancing the ability of the primary mental health workforce in the US, which are the primary care providers. It's often not recognized that most mental health care delivered in the US is actually done by primary care providers in primary care. The particular extension for the LLAMA project that we'll be talking about is delivering that care for people in pregnancy and postpartum, which needs to tie together the pre-pregnancy, pregnancy, and then the postpartum period, which is usually for folks who are under-resourced, the folks coming to community health centers. They're engaging with the healthcare system around pediatric care. So it's really critical that all of those get woven together. So instead of having just the medical provider interacting with a patient, which is the standard model of primary care, we know, we know that adding a team to help out with chronic disorders, whether that's hypertension, diabetes, any number of other kinds of chronic conditions, depression care is greatly improved on the order of 2 to 3 times the benefit for patients who have the addition of a care manager. And you'll be talking to some of our care managers who are working with LLAMA later, and a psychiatric consultant. So that's a psychiatrist who is spending part of their time helping out with the delivery or with the review of cases that are on a registry. So a medical provider refers a patient to LLAMA in our case, but collaborative care. The behavioral health care manager then adds them to a registry and reaches out to the patients, interacting with the patient. And then there's a decision once a week for about an hour to whether or not who it is that needs to be reviewed. And those cases are reviewed based on severity and need. And then that information of the recommendations of the psychiatric consultant. There's a little picture of one of my favorite psychiatric consultants that I've worked with. There by his computer. So most of this is done remotely, so they don't have to be there in person. And they then provide recommendations to the behavioral health care manager and medical provider, usually through the electronic health record. And all of that ends up doubling the number of people to tripling the number of people who go into remission, and moving from an average time of remission of more than a year to about 10 weeks for about half of people to improve. So it's a huge improvement in care outcomes. Next slide. This is the impact study, which was done in the greater Los Angeles, Southern California area back in the early 2000s is when they were reported, and just showing the responses. And the focus in that case was on elderly adults, the geriatric community, but we found the exact same results for every population that we've looked at. Next slide. The principles are for evidence-based models. So making sure that the evidence is for client-centered collaboration. You know, everyone is focused on taking care of that patient as a team. Population-based care, so the use of registries and proactive follow-up so we don't lose track of people. We're not just taking care of the people who show up. Treatment to target, so using the PHQ-9 and other metrics to just the way you would a blood pressure reading to guide treatments is really critical. And then evidence-based care using cognitive behavioral therapy and other evidence-based psychotherapies and medications as needed and appropriate for the support of our patients. And then accountable care, which is key to population-based care, making sure that we are, as a team, taking care of those individuals and populations. Next slide. It's complicated to switch over to collaborative care. There's a big, long process. I show this to you not to go through all the details, but rather to give you a gestalt of, you know, it is a big deal to help a team move from our traditional model of one provider with one patient to a team-based approach, but it is well worth it. Next slide. This is just an example from one of the study that led up to the LLAMA project, which was the MIND-I or maternal infant dyad implementation study, just showing one example of the tremendous improvements that you can see in one needed part of this care, which is going from about 25% of the people in pregnancy and postpartum were being screened the way they should for depression. And that's even when someone says they do it for everybody. I promise you, almost always, without looking at it, it's going to be a lot less. But with attention through a quality improvement approach, which is key to this, with our cyclic PDSA cycles that I showed down below, we get very high rates of adherence to the screening rates. So they're completely doable using the tools that we all are very familiar with now. Next slide. Great. And I'll hand it off to Matt Moyer.
Great. Thanks, Ian. And thanks for laying out the goals of this work using the collaborative care model and really the past successes that you and your team have had in implementing this in Washington and Southern California. On the next slide, the University of Washington and CCLAC, we were approached earlier on by the California Healthcare Foundation to implement a similar program in Los Angeles. And we had a whole planning phase with a number of community members, we had providers, and we really developed the program, which kicked off in 2022. And as you can see here, this program is a 5-year initiative. It engaged a number of different partners to work with community health centers in Los Angeles. So we looked to our CCLAC membership to do this program, and we continue to be the administrator of this. And you can see it's a 5-year initiative to identify and treat common perinatal mood and anxiety disorders and to reduce the risk of suicide, as you've already heard with this model. On the next slide, this really represents the partners in this program, and each play a really important role in implementing a program of this size. We have the AIMS Center and the University of Washington, who are really the experts that implement this or have implemented it in the past, and they've helped train our providers and consultants and really help guide the program implementation and support, the primary care and behavioral health care needs that are addressed through patient treatment and services. We have Elevation Health Partners, and CCLAC has had a long relationship with them and offering consultant expertise in program implementation, quality improvement. They have a whole host of coaches and a couple that are assisting us with maternal health care. EHP has had coaches that assist our members. They're really helping assist our members in more of the day-to-day and helping guide the success of their program with LLAMA. UCLA, there are partners. They're helping. They have an evaluation team helping to monitor the challenges and successes of the program. We have Maternal Mental Health Now. This is an organization that has worked for many years in the field and helped provide an echo series, some case conferences that really help support all of the providers implementing this work at each of their health center sites. And then we also have Concert Health. They've been on board to help us look at billing and financing programs in perinatal mental health services and really help us consult on the program. So you can see lots of different players that have helped implement this program in Los Angeles. So Amy will get a bit more into the details of the program and the participants, but there's really two main offerings for learnings. And we have a partner collaborative and then other training series that are offered to our providers that really bring them all together to share best practices with one another. And there's these two main levels of support. So I'll go ahead and turn it over to Amy to take a deeper dive into the model that we've set up in Los Angeles.
Thanks, Matt. Yeah, as Matt mentioned, LLAMA offers two levels of support for perinatal mental health care. The first level of support is the Collaborative Care Model Implementation Learning Collaborative, which supports community health centers in Los Angeles County to implement the Collaborative Care Model. If you go to the next slide, you'll see that it includes 24 months of intensive coaching support tailored to each health center site, which includes support and technical assistance around developing interventions and building effective workflows for the screening and evaluation of perinatal patients, as well as clinical trainings, generally in the form of webinars and case conference calls to support capacity building. The second level of support that we offer through LLAMA is the ECHO Perinatal Case Conference Series, which supports providers of all disciplines serving Los Angeles County's perinatal population. The 10-month CME accredited series includes didactic content on risk assessment and management of perinatal mental health, as well as in-depth case presentations, case consultations, and group discussions facilitated by a multidisciplinary team. Go to the next slide. In today's webinar, we'll be going into more detail about the first level of support we offer through LLAMA, or the implementation of the collaborative care model. So this learning collaborative supported 4 separate cohorts that were phased throughout a 5-year implementation timeline. And the cohorts included a total of 16 health center sites from Ultimate Health Services, Eisner Health, St. John's Community Health, Clinica Oscar Romero, and TCC Family Health. On the next slide, you'll see the main goals and objectives of program implementation that were focused on the following clinical quality measures and implementation outcomes. We wanted to see health center improvement in 3 clinical quality measures around depression screening and follow-up care for prenatal, postpartum, and well-child visits. And we set as our goal a screening rate of greater than or equal to 80%. And we also sought to support health centers in building their capacity to be able to report on these measures on a monthly basis. And then as far as implementation outcomes go, we wanted to ensure health centers could report on a quarterly basis the depression response rate of patients with common perinatal mental disorders, or CPMD, and that 40% of patients in the caseload experienced a significant reduction in their depression symptoms, specifically that their symptoms decreased by at least 50% after a treatment period of 10 weeks or more. We also wanted to see that care teams conducted systematic case reviews every week, just ensuring that caseloads were evaluated regularly to improve patient engagement and patient outcomes. On the next slide, we can see a number of notable successes and key achievements, as well as challenges that our health centers have faced in implementing the program. As far as successes go, participating health centers were able to establish consistent tracking and reporting of clinical quality measures to monitor and improve perinatal mental health outcomes. We also saw the successful implementation of PDSA cycles to refine and improve screening and documentation practices for prenatal and postpartum depression. Health centers participating in LLAMA demonstrated overall improvement in their screening rates, leading to earlier identification and intervention for patients experiencing perinatal mental health challenges. The program also helped health centers to develop standardized workflows for referring patients and enrolling them in treatment, reducing delays and ensuring a more streamlined transition in care. And we saw the increased reach of the collaborative care model, with some health centers expanding these services to additional sites and increasing access to comprehensive perinatal mental health support. As far as challenges go, limited resources made it difficult to sustain the expanded workload required for the implementation of the collaborative care model across multiple sites, and ensuring buy-in and engagement from providers proved challenging as well. Health centers faced some difficulty in fulfilling the psychiatric consultant role, hindering the model's potential for full integration and impact. And they also saw challenges in tracking and reporting pediatric screening data, limiting the ability to assess broader family mental health outcomes. Furthermore, billing and coding processes created barriers to reimbursement for services provided under their collaborative care model, which impacted financial sustainability. And some health centers faced resistance to a new model of care due to unfamiliarity with the collaborative care model and concerns about just the integration of a new care model. Today, we'll be hearing more about the successes, challenges, as well as additional insights from two FQHCs that implemented LLAMA at their health center sites. And I will turn it over to Cassia Brockway, practice transformation consultant at Elevation Health Partners, who has been instrumental in providing coaching and consulting support to our health centers to successfully implement LLAMA. And with that, I will turn it over to Cassia to introduce herself and our two health centers that we are featuring today.
Thank you, Amy. So as Amy mentioned, my name is Cassia Brockway, and in this capacity, I've been working as a practice coach with some health centers to support the implementation of collaborative care, but also to build the foundations for sustaining the model. So beyond the 24-month coaching support period, our goal is really to build the capacity to sustain the model, hopefully forever. And so I'm really excited to be introducing two FQHCs who are excellent models for the collaborative care model. They've been really successful in implementing this. And so first, we will be starting with AltaMed. They are a federally qualified health center who serves nearly 500,000 patients annually, and they're on a mission to eliminate disparities in healthcare access and outcomes by providing superior quality health and human services through an integrated delivery system for Latino, multi-ethnic, and often overlooked communities in Southern California. They've successfully implemented and sustained the collaborative care model in the first cohort of LLAMA across 2 sites. And so I'll go ahead and pass it over to Jillian to tell us more about their experience.
Hi, everyone. Good afternoon. My name is Jillian Johnson. I am an LCSW, one of the behavioral health managers within our behavioral health department. And I'm so happy and excited to be here to tell you guys about our implementation of LLAMA and how we're continuing to expand and grow the program and making some changes that we've learned from University of Washington and all of the collaborators here today. You can change slide, please. Just a little overview. Our agenda is going to be our implementations, our challenges, and our wins. And of course, I have the little picture here that Dr. Bennett shared as well. This was like the main thing in all of our trainings, to show everyone what collaborative care looked like and how it was supposed to function so that we all are on the same page. So the first slide here is our LLAMA implementation. So AltaMed actually had 2 sites, our West Covina site, as well as our Commerce Goodrich site. So the biggest part of implementing for us was really training our staff. When we got the information, we really had our LLAMA champions really know what was collaborative care, have that buy-in from our champions, right? Because we needed them to continue to successfully tell other providers and the clinics what the collaborative care model was and how to implement it. We did go towards some monthly team meetings. It was a little rocky at first, but I think this was a huge plus for us because we were able to meet with all of our teams, discuss, make changes, make adjustments, and see what was going wrong, what was going well. And that way we were all on the same page. So these monthly team meetings with our champions as well as our clinics was really helpful. We had a lot of clinic trainings, which were virtual or in person. So we had our front and back office in the trainings. We had our providers as well as our clinicians. And we really wanted to focus on keeping these trainings going every few months because we do have a lot of turnaround, right? There's changes in providers, there's changes in back office, front office, not just leaving or coming to Altamed, but also maybe promotions, changes in their roles. So we really needed these trainings to be continuous. Next slide. And a big part of the trainings was really these clinic presentations. I always say in person is best because you get that interaction, you get to take some food, everybody has some buy-in, and it was just a great environment for everybody. So our clinic presentations were really just that, us educating everybody, what was collaborative care, how are we going to implement this, and what did it mean for our providers and our staff to work as a team. We also implemented grand rounds. So at Altamed, on a monthly basis, we do have somebody that presents on a topic, on something that is helpful for all our staff at Altamed. And one of the topics was on collaborative care. Dr. Ko led this grand rounds. I was in support and talked about the collaborative care piece, how we were working with patients, and she really talked about the psychiatric consultant part, how she was helping providers feel more comfortable in providing or prescribing medications and not feeling so scared to do it. I know that was something that was a challenge for us, but the grand rounds and Dr. Ko's support really helped providers feel comfortable. We also did a lot of training on the overview of the PHQ-9 and how to document, just because we want to make sure documentation is there for collaborative care. If they decline services, just so that we are all on the same page when we open a patient chart and we're trying to get the buy-in from the patient as well. Those approaches for patients. I think when we did our first training, the elevator speech was great. It really helped us really talk about what the program was, how to approach patients, and it gave the providers as well as our support staff that confidence to say this is what our program is and it's going to be something beneficial for you and you have a team that's going to work with you. The bigger piece was also the how to refer to services, because we really had to be strategic about this part because our behavioral health queue is huge. So we wanted to make a different referral process for the LAMA patients just because it was going to be a more specialty program. And we really wanted to get those referrals sent directly to us so we are able to schedule those patients in a timely fashion. Next slide. So the big part, like I said, was creating workflows for these referrals. We want to make sure everyone knew exactly what they were doing and how they were referring to us, so it wasn't any confusion. So providers and pediatric providers were given a referral workflow, as well as our OB-GYNs, our women's health, and then our comprehensive perinatal health workers, which are our CPHWs that do PHQ-9s. They also do the postpartum depression screeners at their screenings. So that was a plus for us because that was another person we were collaborating with in our clinics that was making a lot of referrals to us. So these were either done by internal referrals, Epic secure chats, because Epic's our electronic health record system here at Altamed, our emails, or in basket messages. Next. Just an example, I'm a visual learner, so I thought I would share with you what we presented to our providers because I think this is easier for them to understand as well as a bunch of bullet points, right? So we did have our OB referral workflow, completing the PHQ-9s, discussing results and collaborative care, and then if the patient agreed, they would do a referral into our maternal mental health queue. If not, then we would make sure that the provider did document just so that we know the patient declined and they can always offer their services later. One thing to just note, we did emphasize that we wanted patients that did score 5 or above. I know a positive PHQ-9 is 10 or above, but we actually use the patients that fell into that 5 to 10 as preventative care. So we found that as an opportunity for our patients to learn some preventative coping skills so that the symptoms did not increase during that perinatal timeframe. And then the bottom referral workflow is for our CPHWs. So they would also do the PHQ-9s, submit in an in-basket message to us, and our case managers call the patients and schedule them on the clinician schedule. Our pediatric workflow was a little bit unique. We did not want to put any parent information in a baby chart. We didn't want to put the PHQ-9 score in that baby chart only because it's not theirs. So we wanted to make sure that we were doing the PHQ-9s, which was at first a paper PHQ-9. Provider would go over it. They would refer to us through an in-basket message or a secure chat or an email, whichever they felt comfortable with. But I feel like in the time frame that we did this, secure chats were the biggest thing that providers use because it was direct, it was fast, we responded right away, as opposed to an in-basket message that could be sitting there for a few days. The secure chats came right away to us. So that was a little bit of the change in the workflow for our pediatric team. We did keep a list of those patients just because we didn't want to have any of that in the baby chart. Next slide. And this was just a sample of our patient flyer, which was awesome. And I know it seems a little bit wordy, but I think it was helpful for the patient to understand you as the patient. This is what is expected of you. This is your provider. This is the behavioral care manager, as well as a psychiatric consultant. So everybody knew what they were getting into and who the team was. Again, us as behavioral health care managers, we discussed it again when we did our intakes and we talked about these team efforts. And something to remember that I do remember is patients at first were a little bit like, it's too much checking in. There's too many people calling. There's just a lot going on. But at the end of treatment, it was a very different story. Those patients were like, I do appreciate this now. I actually appreciate now all of the check-ins you guys made, or just everybody being on the same page, you asking if I wanted to talk to, you wanted me to talk to the doctor, anything we needed to consult about, patients were on board with it at the end. So you kind of see this shift in patients as well, where they felt a little overwhelmed at first, but as the time went by, they really appreciated all of the team care. Next page. Challenges. So biggest challenge that was mentioned before, collaborative care model billing. We are working on it still today. We are working on an epic build, which I'm fingers crossed we get it going and it's going to be beautiful and it's going to work, but hopes, right? So we are still not billing as we speak, but hopefully we will. We did use the CPT codes just for the therapy services, but we just used the collaborative care model, just no billing at that time. Our EPIC EHR challenges, one was the registry. So I know through University of Washington, we were going to do the registry, but due to PHI, we went through using the Excel spreadsheet, still have that. The next hope is once our build is done, I'm going to suggest we do our registry, which will be so much easier and better because it'll pull all that data from EPIC. So baby steps, we're getting there. So these were some of the challenges in our EHR. The other challenge, like discussed earlier, was just the comfort of providers prescribing medications. Dr. Ko did a great job at doing consultations. She was always available. If I made secure chats for providers as well as her, I would always attach that and ask for suggestions. She did smart phrases in Epic. She sent tip sheets. It was just a really great collaboration with Dr. Ko, where she really made the providers feel comfortable in prescribing the medications. If there was any change that I saw in the patient, right away I would tell her and I would tell the provider, and they work together as a team. So that was just a little challenge at first, but I think providers got a little bit more comfortable. And again, challenges with staff, continuing to train because of changes in their roles, or, leaving or coming to Ultimate, there was always changes in staff. We had changes as behavioral health care managers. I lost one, so we had to get someone trained. And, I myself was doing patient care as well as leading the initiative. So it was, I got the best of both worlds. I got to see how it all worked as a clinician, as well as the other part of all the operational side of it. So it was great. Next slide, please. This was one of our biggest challenges, was the PHQ-9 during the Watch Child visit. We are improving today. So our EPIC team was gracious and they helped us create a dot phrase, which was period maternal PHQ-9. So this was a maternal PHQ-9 that populated in a note, and it disappeared as a hyperlink, right? So once they closed that note, the link was gone. There was no access to the PHQ-9, but the PHQ-9 was recorded in the flow sheets. So we would be able to see a title of maternal PHQ in the chart, and it wasn't titled as the baby's PHQ. So that was nice for us to have. We did provide tip sheets. It was a little confusing at first for our back office. So we had to do a little extra training. I think today we're a little bit better with it. So I've seen the percentage of PHQ-9s being electrically inputted in the system, electronically put in. So I think we're getting there. It's still going to be a continuous workflow for us that we change. And I know Dr. Bennett had suggested, some more trainings on PHQ-9. And guess what, Dr. Bennett? That's what we're doing. We are going to do a 2-series PHQ-9 training, which will be, learning what the PHQ-9 is about, why we administer it, how to administer it, and how to help back office, front office, whoever's going to do it, feel comfortable. So that is going to be launched very soon as we've created the training already. Next slide. And then some llama wins. I'll try to go quickly through it. Improved completion of PHQ-9. So from the beginning to the end of the grant, we did see a huge increase of percentages that were coming in of providers completing them. So that was great. A slight improvement in the pediatric visits, and we're seeing more improvement now. And then continued support from Dr. Ko, our psychiatric consultant, and then continued trainings and education. So this is a huge win for us because at the bottom I put clinic leadership and staff always equals teamwork, right? So I think once we get all of our leadership and our staff on one page and everybody's on board, we have this great, team, and we have everybody buying into the model and really how it helps patients, not just the patients, though also the providers, how it alleviates some of that stress from the provider and the behavioral health care manager, because we're all working together. Next slide. Program changes and expansions. So we did change it. Obviously, we ended our cohort 1 in January with Llama, but we did change our program to parental support program. So now that's going to encompass more, and we want to make it just more for patients to feel like it's a program itself in its own entity, right? So parental support program, we're continuing the whole perinatal population and time frame. We do have a full-time clinician now that is seeing patients from both sides. So that's a huge win for us because every day she sees our perinatal population. And I'm supporting that clinician. So it's really great to see that patients are being seen very quickly. Another change that we've done to the program is we have added some groups. So hopefully we'll be launching those in our next quarter. I did do a postpartum support group at the end of the Llama project, and it was a huge success. Patients really resonated with it. They loved it. They liked the peer interaction. So it was a win for us, and we really want to continue those as well as part of the collaborative care piece too. And then our last piece is collaborating with Epic to create that build. So like I said, we're working on that. Hopefully at the end of this month, we will have the team show us how to work with it. They will train us and we will be able to move forward. And I'm hoping those codes will go through and we will be able to start billing. So a lot of wins, a lot of growth, and hopefully we'll be expanding next year, 2026, to a couple more clinics. That's it. Thank you, guys.
Thank you so much, Jillian. That was a really great deep dive into the work that you all have done, and as well as some really great tangible tools that I think participants can take away from that. So thank you so much. And I'm excited to next introduce Eisner. So they are another federally qualified health center that is still working in the Llama project, serving 40,000 patients annually in Los Angeles County. They provide culturally competent, full life cycle medical care, prenatal care, labor and delivery, women's health services, behavioral health, case management and care coordination, supplemental services, and more. They've successfully implemented and sustained the collaborative care model in the first cohort of Llama across 2 sites, and they've also since expanded to 2 more sites participating in the Llama program in downtown LA and Linwood. So I'll go ahead and pass it over to Dev.
Thank you, Kasia. Thanks, everyone. Thank you very much, Jillian, for your presentation. It like rejuvenated why we do this work. I could hear that enthusiasm. As Kasia mentioned, I am from Eisner Health. We are an FQHC. And my role is the director of behavioral health. And in the Llama project and implementation process, I was the lead in the clinical implementation team. So working with the medical provider champions and working with our behavioral health care manager, our QI department, I kind of worked in just helping facilitate meeting not just objectives, but really just assisting and with the guidance of our coach, um, creating smooth processes so that we can get access to care to our population of need and of focus. So as Kasia mentioned, we are throughout LA County, and we are participating in two different cohorts. So our first cohort, which much of our learning process and I would say learning points were experienced there was done in the Valley, Van Nuys, Panorama City, and currently we're participating in cohort 4, where we were able to adapt a lot of our lessons learned for our downtown Women's Health Center and also our Linwood Clinic. So we can go to the next slide. As Kelsey mentioned, these are just some of a snapshot of our services that we currently provide at Eisner, and making it, I think, really just a strong foundation for collaborative care. And as we can go to our next slide. And I want to talk about like why this just made a great fit for Eisner. Eisner is a strong practicer, I should say, of integrated care. It was not a new concept for us. We believe in integrative and team whole-based care. And so we were ready. We actually had pre-existing workflows that allowed for a smooth transition as we were adapting with the guidance of our coaches and the structure that Llama was providing. It really just strengthened some of the work that one was in process and two, we were trying to expand. Within our clinic, we already had a streamlined process for screening for maternal mental health at every OB visit with the PHQ-9, which was a plus because this was not going to add any work to our MAs and other support staff because this was something we were already doing. However, what Llama did do was provide some structure and guidance that really just cleaned up some of the work that was being done by really providing the tools needed for communicating workflows, making those adjustments. And part of those adjustments, again, were in the expansion plans that Eisner had in expanding screening at our pediatric newborn visits. We were originally looking at just screening from 0 to 6 months when we joined and participated in our Llama cohort 1. And so we made the adjustment that based on the research that was provided to us, and when we're encouraged to expand, instead of 0 to 6 months, we were screening 0 to 12 months. And so we made that adjustment in the workflow that we were creating. As Jillian mentioned, like Ultimate, we also found challenges in documenting properly what that maternal mental health screening looked like in the newborn chart without it appearing that it was the newborn who was actually being screened. So we also created a macro and a workflow with labels that clearly specified maternal mental health screening so that it was distinguished and that a score could be recorded but not accessed easily within the chart. Also making sure that when we did our QI reports for PHQ-9s, that this wasn't misinformation that was being communicated. So definitely work closely with our IS team. Our EHR is Athena 1. And so that was kind of a little bit also a challenge because it was brand new to us. We were in the process of transitioning to a new EHR system, but our IS team provided great supports for us. We worked with our medical providers, which also was just the champions just didn't talk about the clinical work, but they were a big part of the IS conversations because we wanted the workflow to make sense and not added burden to our medical providers who are actually doing the screening during our visits, whether it was OB or pediatric. I also, we looked at our mental health, our behavioral health department and our referral processes. Again, behavioral health and integrated care isn't brand new for Eisner, but we did look at our processes and we had to do minimal modifications to ensure that we were linking patients to the behavioral health care manager, who is, as Jillian mentioned, is the role who is really key to the collaborative care work that's being done between the medical, behavioral health, and the site consultant. And so we looked at those modifications, we trained some staff on integrated behavioral health care, retrained on proper documentation so that the administrative team that was supporting the patient with linking them to care, it was clearly identified that this would be maternal mental health LAMA, and we would get them linked to the right clinician in the most, I would say, a short amount of time. And so with that, I just want to highlight, we have a highly skilled staff in team-based care. Integrated behavioral health is something that's really important to Eisner, our behavioral health team, our medical team. So I say that because buy-in was easy. This was a program and a resource that was highly desired and really created a lot of excitement amongst our medical team and behavioral health team to just strengthen the supports at the benefit of our patients. You know, we understood the better we communicate, the stronger that we collaborate, the best positive outcomes for our patients in meeting their goals and helping them do the transition, especially in parenthood and motherhood. Adapting collaborative care model really did mirror a lot of the clinical practices that our IBH model already had in existence. But again, with the retraining that we received through the LAMA and our LAMA project, it really just highlighted the skills that existed, but also just kind of reinvigorated the work that was already being done and really kind of became more purposeful is the word I want to look for, like more purposeful in what we were doing. Next slide. Some of the lessons learned and what we were as we were starting was language matters. We were really excited, as I mentioned, about adapting LAMA and engaging with a psych consultant and having this resource for our provider. So much so that when we did our original draft for how to introduce, as you know, the elevator speaks, how to introduce this program or this opportunity for patients to be supported by a behavioral health care manager, much of our original draft included the support from the psych consultant and the psychiatric services that would be readily available. Because to us, it was really exciting. It was not something we had in existence at Eisner. We do not currently have a full-time psychiatrist that supports adult population. So to have the support for medical providers, we were extremely excited to have this resource. However, it overshadowed the fact that we were ignoring the stigma behind this. And so in our original draft, as much as there was excitement about this is resources that we have, such as, you know, our primary care would be working with a psych consultant, you would be able to be supported with medication if needed. It really didn't take into account that trauma-informed care conversation that we knew about. And we quickly realized that we weren't recognizing the stigma and weren't really being sensitive to the fears around medication, especially for our nursing mothers or those who were expectant in the perinatal aspect of things. So with our scripts, we redrafted, took a step back because we noticed that referrals were moderate and not as high as we anticipated. And so with our redraft, we sat down and we recognized the stigma. We wanted to be really sensitive in the language that we were using. We wanted to acknowledge the fear around psychiatric medication in this particular time in a patient's life. We emphasized that the treatment team aspect, really the collaborative aspect. That was really what we highlighted in our second round of script and really spoke to each other, not as a department or as a person, but as another team member that was here as a treatment team for our patients. Our language was carefully reviewed as we looked at our marketing flyers, and we wanted to make sure it echoed what was being said in the exam room and was reflected in our flyer. We wanted really to make it uniform. And so that was a big takeaway for us, that language matters, being sensitive to patients' concerns and being mindful of the stigma that exists and the fears that exist, particularly around this particular population with psychiatric meds and supports, although beneficial, also have concerns as well. And so we normalized those questions, normalized those concerns, and just were really sensitive to how we were introducing this program. And we saw that when we started seeing increases. So thank you for that. If you could go to the next slide. The other lesson learned was provider support. So our team includes family practitioners, OBs, pediatricians, PAs, certified midwives, all with different comfort levels of providing medication. all with different experiences of already doing some of this work. As Dr. Bennett mentioned, it's not uncommon that primary care already engages in some type of support in behavioral health, but we acknowledge that not everyone has the same degree of comfort. And so we surveyed what kind of supports they would need. And one of the big asks was literature that supported the work that we were doing and the changes as far as expanding the screening, literature that supported the types of medications that would be appropriate. And when engaging a nursing mother or a patient who was expecting, we also encouraged and were mindful of, time restraints, but really promoted through Maternal Mental Health Now, the echo sessions and the series that were being presented. It was really helpful that you didn't have to be there live and that they can go back and watch them later at time. So that was also just made it accessible and doable. Our behavioral health care managers connected with our providers as well, not just via communication through our AHR, but also we're really intentional about speaking with providers in person. So making use of administrative time with the provider, stopping in the provider room. It was not uncommon that they would spend some of their day checking in, not just in the provider room, but also in exams if they knew patients were coming in, and including the care manager in some of those examinations that were being done during the screening. And so we encourage providers to join also in the weekly check-in if needed. Again, reverting back to comfort level. If there were specific questions that were still wanting to be addressed, it was no secret when the care manager was meeting with our psychiatric consultant. And so we made that link readily available for the provider if they would like to join and ask direct questions to the psychiatric consultant in the event that the communication in the EHR wasn't suffice or they had other questions around or follow-up questions to the answer. The behavioral health care manager also participated in the monthly clinic meetings to highlight work that was being done in LAMA. I think just continuing to speak of LAMA and collaborative care really helped support that it wouldn't be forgotten. And it was really just another way of saying that this is a service that it's here to stay. It's not just something we're testing and piloting, but there was intention about making part of our day-to-day with the collaborative work that we were doing. And as I mentioned, the marketing material that was created was not just created for patients, but we also wanted providers to understand the work that was being done. So we presented it to our providers so that the language, again, matched what was being spoken in the examination room. And they also had something tangible that they could refer to. And it wasn't just dependent on memory, but something dependable for them to, whether it was in their provider room, or again, if the MA knew that a patient was coming in that was for a newborn checkup or an OB visit, it's common practice that they would include that a flyer just in case in the exam room, in case the provider needed to refer to that for a conversation. Next slide. Just like Ultimed, we also encountered some challenges with our billing. And so the collaborative care codes, I want to specify, do not cover the time spent with between the behavioral health care manager and the psychiatric consultant. And the behavioral care codes are intended to cover the time that is actually direct care between the care manager and the patient. So it doesn't allow for billing for that collaborative work, and that was something we needed to understand and also communicate that it didn't cover that, but it was for the direct care that was being done. And for Eisner, using the collaborative care codes would mean taking a fiscal law, because we decided to use the CTP codes for behavioral health. As we were, it's still a work in progress for ourselves. We are still looking at our collaborative care codes, seeing what we can do with our IS team and how to best adapt those codes so that we can fully embrace collaborative care, not just in practice, but also in billing practices as well. And so we're currently working with our CFO and our IS team to see what that plan looks like and what changes would need to be made, and training provisions need to be done as well. So this is a work in progress. Currently, we are using the CTP codes for behavioral health that are most appropriate to match the service that was being provided. And in our EHR, we acknowledge that more modifications are going to be needed to capture that data. Currently, the way we do it is we enroll the patient who is receiving collaborative care in their care plan in our EHR. It is identified. So that's how we can distinguish and monitor patients who are actually involved. And so they're not being grouped with other patients who are using the same CTP code, but not LAMA patients. So there were some modifications that we have done, but definitely there is some more work that we're doing in this area. Next slide. And I just want to end with a success story because it really has been helpful to see and hear about the success stories, especially, changes can create a lot of different stressors. But when you hear how patients are being positively impacted, it makes all the work and all the back and forth and the drafting just worth it. And so I want to speak to you and just close with a story about one of our patients named Jenny. Jenny delivered a healthy baby and soon after began the silent struggle with postpartum. She actually missed her OB appointment and was screened at the newborn visit. And so during that newborn visit, the screen occurred and that provider touched base with the behavioral health care manager who also connected with the OB provider, again, that strength and team. And so in that discussion, when Jenny did return to her OB visits, a conversation happened with the OB who introduced the LAMA and collaborative care program, and she was open to meeting with our care manager, our behavioral health care manager. Within a matter of days, she was sitting down and learning about the symptoms she was feeling, learning skills to decrease that, and really just validate it. It's scary to speak of severe postpartum depression, and that's really what she was experiencing. The clinician introduced the resource of psychiatric medications, but Jenny at that time was not ready. And so we continued. There was no judgment. We continued the collaborative care work. And after a couple meetings with Jenny, Jenny voiced that she was ready to discuss next steps in care, and that would include some medication. And so we didn't have to refer her out, but we didn't have to burden her with seeking another appointment with an outside provider. But because we were engaging with collaborative care, we were able to keep her within her health home and didn't have to burden her with more stress. And so the collaborative care team came together. The care manager presented this case and the past PHQ-9 findings to our site consultant. The site consultant was able to review and make recommendations, provide those recommendations with the OB and her OB who was going to be taking lead on this. And with time, we saw Jenny just really begin to gather the strength to apply the skills that she was learning with the care manager and the support. Through her weekly appointments with the care manager, she was being monitored by the psychiatrist. She was engaging with her OB visits and her own wellness visits. A couple of adjustments were made, and we began to see that Jenny began to report decreased numbers in her PHQ-9. We saw her recovery, and she was able to successfully graduate from collaborative care LAMA within 11 sessions. We saw that she was not just feeling well as a mom, but we saw that she was taking care of herself and encouraging fellow patients that she met in the waiting room to engage with our care manager. So she was kind of this advertising, hey, are you working with our care manager? And so we really felt that this was just a validation of the work that had been done to get to this point and really makes it worth it. I think at times, again, change, working with EHR systems and doing new workflows can really be overwhelming. But when you see and hear patients really benefit from that, it just really makes the work all worth it. So, it's something that we are not regretful, and what made our decision to join Cohort 4 very easy. We wanted to continue the work and expand the work, and more importantly, improve our workflows so that patients like Jenny can have access to care and just, experience a positive health. And so I will pass it back over to Kasia, and just thank you again for your time.
Thank you, Dev. That was a wonderful presentation, providing insights into the experiences that Eisner has had, and then it's also just so powerful to hear that patient story and the direct impact that those patients feel when they have this team-based care model. So thank you. All right, I will go ahead and pass it back over to Marie to close us out.
Thank you so much. Thank you so much to all who stayed on with us for the hour. And thank you so much to our speakers for sharing the amazing work that's happening in Los Angeles. Thank you, Dev. Thank you, Jillian. And also the work that's happening with CCLAC and then, of course, with Dr. Bennett. I know there's some questions in the chat. But given the time, we're going to take those questions offline and provide responses to those in the post-webinar email, which we'll be sharing in a few weeks, along with the recording of this webinar for those who were unable to join us today. So again, join me in thanking our amazing speakers for today, and thank you all for completing the evaluation and being with us and taking time out of your day. We hope to see you at a future CIN event. Thanks, everyone. Have a great rest of your day.
Thank you.